Welcome back to the Deep Dive. This is where we take the topics you send us, often revision notes, and really break them down.
Yep, aiming for clarity and making those key facts stick.
And today, we're diving into Hereditary Spherocytosis, HS. Based on the notes you provided, we want to give you a really solid overview for revision.
Exactly. So, HS, what are we actually talking about?
Okay, so picture your normal red blood cell. It's that kind of flexible biconcave disc shape, right? Like a, I don't know, bouncy basketball maybe?
Yeah, good analogy. Flexible is key.
But in HS, those cells end up more like spheres. Think maybe a slightly deflated basketball. Not as bouncy, not as flexible.
And that shape change is the whole problem. It makes them fragile. They get destroyed way too early, and that leads to anemia.
So the formal definition.
Well, hereditary spherocytosis is an inherited hemolytic anemia. It's marked by these spherical red blood cells, the spherocytes, and it's all down to defects in the proteins that maintain the red blood cell membrane structure.
Leading to fragility and early destruction in the spleen. Right.
Primarily in the spleen, yes. So the basics to really nail down are it's inherited. It causes hemolytic anemia. It's actually the most common hereditary hemolytic anemia in people of Northern European descent.
Yeah.
Usually an autosomal dominant defect affecting that red cell cytoskeleton, changing the shape from that biconcave disc to a sphere, and ultimately reducing the red blood cell's survival because the spleen clears them out.
Got it. That's clear. Let's talk etiology then, the underlying causes. You mentioned protein defects.
Yeah, exactly. It comes down to mutations in the genes that code for these crucial red blood cell membrane proteins. Think of them as the internal scaffolding of the cell.
And which proteins are we mainly talking about?
The big ones are ankyrin, band-3, alpha spectrin, beta spectrin, and protein 4.2. Spectrin, for instance, forms this kind of meshwork just under the membrane, giving it strength. Ankyrin helps anchor that meshwork to other proteins like band-3.
Okay.
Yeah.
And inheritance pattern. You said mostly autosomal dominant.
That's right, about 75% of the time. So you only need one copy of the mutated gene. But you can also see autosomal recessive forms needing 2 copies, or even de novo mutations, totally new mutations that weren't inherited.
Right. So given the inheritance, the main risk factor is pretty straightforward then.
Absolutely. It's family history. If you have a close relative with HS, your risk is significantly higher. That's really the main one.
Makes sense.
Yeah.
Okay, pathophysiology. Let's get into how these faulty genes actually cause the disease. This is where the mechanism comes in.
Right. So those gene mutations lead to abnormalities in those proteins we mentioned, ankyrin, spectrin, et cetera. This basically weakens the red cell structure.
Makes it less robust.
Exactly. Less able to handle the mechanical stress of, circulating round and round, especially squeezing through the tiny passages in the spleen.
Ah, the spleen again.
Always the spleen in HS. A key thing that happens is the cell membrane loses surface area relative to its volume. Go back to your basketball analogy. If you chip bits off the surface, it changes how it behaves.
Becomes less bouncy, less flexible.
Precisely. The red cells become less deformable, less able to change shape, and they also have increased osmotic fragility. That means they're more likely to burst if the salt concentration outside the cell changes. This loss of surface area and deformability forces them into that sphere shape.
The spherocyte?
The spherocyte. And because they're rigid and abnormally shaped, they get trapped in the spleen's filtration system.
And destroyed.
Leading to hemolytic anemia. The clinical severity, how bad the anemia is, really varies depending on which protein is affected and how badly. It all relates back to how much surface area is lost and how rigid the cell becomes.
So the spleen is just doing its filtering job, but it ends up causing the anemia by taking out these fragile cells too efficiently.
That's a good way to put it. And just to hammer it home, the key proteins to remember are alpha spectrin, beta spectrin, ankyrin, and protein 4.2.
Got him. Now, differential diagnosis, seeing spherocytes on a blood film isn't only HS, is it?
No, absolutely not. That's a really important point. You have to consider other things.
Like what? What else is on the list?
Well, probably the most important differential is autoimmune hemolytic anemia, AIHA. Here, the immune system attacks the red cells, and sometimes that makes them spherical.
How do you tell them apart?
The key test is the direct antiglobulin test, or DAE, sometimes called the Coombs test. In HS, it's typically negative, no antibodies sticking to the red cells. In AIHA, it's usually positive.
Okay, crucial difference. What else could mimic it?
There's quite a list, actually. Other types of hemolysis, like microangiopathic ones where cells get physically sheared, or macroangiopathic. Hemolytic transfusion reactions, obviously.
Right.
Then some more, maybe less common things, but still possible. Severe burns, certain injuries from oxidants, even snake bites. Liver disease can sometimes do it.
Really?
Gee.
Liver disease.
Yeah. And things like clostridial sepsis, Heinz body anemias, zinc toxicity, severe low phosphate levels, even an overactive spleen, hypersplenism for other reasons. And in newborns, ABO compatibility is a classic cause of spherocytes and jaundice.
Wow, okay. So there's a wide range. The notes mention a memory tip, something about spheres and arenas.
Yeah, spheres appearing in various arenas of the body due to different incidents. It's a bit abstract, maybe, but the point is don't jump straight to HS. Look at the whole picture, the other tests.
Context is key. Right, let's zoom out epidemiology. How common is this condition?
In the UK, the prevalence is estimated somewhere between 1 in 2,000 and 1 in 5,000 people.
Okay, so not incredibly rare.
Not at all. And the incidence, so new cases, is maybe 1 in 2,000 to 1 in 10,000 births. And again, that inheritance pattern. About 3/4 autosomal dominant, the rest recessive or new mutations. So you will encounter it.
Good to know the numbers. No, clinical features. What does someone with HS actually look like? What are the signs and symptoms?
Well, the underlying issue is chronic hemolytic anemia. So the classic triad you might see is fatigue, pallor, looking pale, and jaundice, that yellowing of the skin and eyes.
Because of the bilirubin buildup from red cell breakdown.
Exactly. Then more specifically for HS, you might see failure to thrive in kids, the jaundice can be quite noticeable, and gallstones are a common complication.
Why gallstones?
Again, it's the chronic hemolysis. All that extra bilirubin being processed by the liver and excreted in bile can lead to pigment gallstones forming. Splenomegaly and enlarged spleen is also really common because, well, it's working so hard clearing those cells.
Makes sense.
And a really important one to know is the risk of aplastic crisis. This is where red cell production in the bone marrow just temporarily stops, often triggered by a parvovirus B19 infection.
The slap cheek virus.
That's the one.
Right.
It can cause a dramatic drop in hemoglobin. You also see just generally variable levels of hemolysis over time and often a high MCHC on the blood count.
Ah, yes. The mean corpuscular hemoglobin concentration. Why is that typically high in HS?
It's mainly thought to be due to relative dehydration of the spherocyte. Because they've lost surface area compared to their volume, water tends to leave the cell, concentrating the hemoglobin inside.
Okay, like squeezing water out of a smaller container, that helps visualize it. And the severity varies?
Yeah, definitely. It's often categorized mild, maybe 20–30% of people might just have slightly increased red cell turnover, maybe feel fine. Moderate is the biggest group, 60–70%, usually presenting in childhood with obvious anemia.
And severe.
Severe cases, often presenting in newborns, especially those with Northern European background, can have really severe jaundice, sometimes even needing exchange transfusions right after birth.
Wow, there was a mnemonic in the notes for the common signs.
Yep, judges of failure. Helps remember jaundice, gallstones, splenomegaly, and failure to thrive. Quite neat.
JGS of failure. Got it. Okay, investigations. How do we actually confirm the diagnosis?
It's usually a combination of those clinical features we just discussed and specific lab results. You'd start with a full blood count, the FBC.
Looking for anemia and the spherocytes themselves.
Exactly, and checking that MCHC. Then you'd want a reticulocyte count. Are they elevated? That shows the bone marrow is trying to compensate for the haemolysis by churning out new cells.
And the blood film is crucial.
Absolutely critical. That's where you actually see the spherocytes and often polychromasia, which indicates lots of young red cells, the reticulocytes.
Okay, what else?
Liver function tests, LFTs. You're looking for signs of hemolysis. Raised unconjugated bilirubin, high LDH, lactate dehydrogenase, maybe increased urobilinogen in urine or feces, and importantly, low haptoglobin levels.
Because haptoglobin binds the free hemoglobin released.
Precisely. When lots of cells break down, the haptoglobin gets used up. And don't forget the direct antiglobulin test, the DAAE or Coombs test.
To rule out autoimmune causes.
Yay.
Should be negative in HS.
Typically negative, yes. Now, older tests like osmotic fragility aren't used as much. They're not as specific. More specialized tests exist, like osmotic gradient ectocytometry.
Ectocytometry.
Yeah, it's a fancy way of measuring how red cells deform under stress. It's very good for confirming HS and distinguishing it from similar conditions like hereditary stomatocytosis. And in really tricky cases, you might do protein analysis of the membrane using electrophoresis or even genetic testing to find the specific mutation.
Right, quite a detailed workup possible. Another mnemonic for investigations.
There is. FilRed. Think film, blood film, iron FBC, LDH LFTs, Redix, and direct Coombs.
FilRed. Excellent. Okay, management. What are the treatment approaches?
It's mainly supportive care, and it really depends on how severe the HS is for that individual. Folic acid supplementation is standard.
Why folic acid?
Because the bone marrow is working overtime making new red cells, it uses up folate faster. So
Mm.
you supplement to prevent deficiency. Regular monitoring of hemoglobin levels is also key. Blood transfusions might be needed for severe anemia or during those acute crises, like in a plastic crisis.
And the big one, splenectomy.
Yes, removing the spleen. It's a major consideration for people with moderate to severe disease. It stops the main site of red cell destruction.
How's it usually done?
Laparoscopically, keyhole surgery is preferred now, if possible. Sometimes partial splenectomy or splenic embolization are considered, but total splenectomy is more common for HS. There's a really important caution, though splenectomy is generally contraindicated in some related conditions, like certain types of hereditary stomatocytosis, because it massively increases the risk of blood clots.
So, a careful decision.
Absolutely. Huge discussion about risks versus benefits. Risks include overwhelming infection after surgery, so lifelong preventative antibiotics, usually penicillin, and specific vaccinations are essential post-splenectomy.
But it can be curative for the anemia.
In most cases of HS, yes. It effectively cures the anemia and the jaundice because you've removed the primary site where the fragile cells were being destroyed. For acute crises, management is supportive rest, fluids, transfusion if needed. Long-term, it's that folate replacement. Sometimes steroids might give a temporary boost to hemoglobin during a crisis in moderate cases, and genetic counseling and family tracing can be important too.
Do people need constant blood tests once diagnosed?
Not necessarily. Once the diagnosis is clear and you know their baseline severity, routine tests might become less frequent unless something changes.
Okay. And the overall prognosis?
Generally good. With proper management, monitoring, and splenectomy if needed, most people live pretty normal lives. But you do have that small group, maybe 3–5%, with severe disease who remain transfusion dependent even after splenectomy or who can't have one.
Right. Finally, complications. What are the main things to watch out for?
Gallstones, cholelithiasis are definitely up there. That chronic hemolysis and high bilirubin load is the cause. Coexisting Gilbert syndrome can make it worse, but splenectomy usually solves the gallstone issue too.
Okay.
We've mentioned a plastic crisis multiple times, that parvovirus B19 trigger causing a temporary shutdown of red cell production. Usually lasts 10–14 days, but can be life-threatening if hemoglobin drops very low.
Serious stuff.
Yeah. Splenic sequestration crisis is another one, sudden trapping of a large volume of blood in the spleen, causing it to enlarge rapidly and leading to severe anemia. Less common now, but megaloblastic crises from folate deficiency can happen if supplementation isn't adequate. And just generally, people can have hemolytic crises, periods of increased red cell breakdown, sometimes triggered by infections.
So definitely things to be vigilant about, even if the day-to-day is well managed.
Absolutely.
Okay, let's wrap up this deep dive on hereditary spherocytosis. Key takeaways. It's inherited, red cells are spherical and fragile, leading to hemolytic anemia. The spleen is central to the problem. Severity varies a lot. Management includes supportive care, folate, and often splenectomy, which can be very effective.
That covers it nicely. We really hope going through your notes like this has helped solidify the key information for your revision.
Yeah, hopefully that was useful. And if you want more practice or resources, especially for the MSRA, do check out pastthemsra.com and also freemsra.com.
Great resources. And maybe a final thought to leave you with. We've talked about different protein defects causing HS. Thinking about that diversity, what other seemingly simple cell parts might actually hide similar complexities in other inherited disorders? And how does digging into these molecular details really pave the way for more targeted, maybe even personalized treatments down the line? Something to ponder.